Another feature of evaluations in public health are we tend to see a much wider range of study designs. And that's probably because it's quite difficult, sometimes impossible, to have a randomized trial in public health. Part of the challenge there is the public health frequently doesn't have an individual focus. And if an intervention doesn't have an individual focus, randomization of the recipients becomes much harder. It might be that randomization is still possible when we're evaluating public health interventions, but it doesn't happen very often. And the reason it doesn't happen very often is we don't seem to regulate public health. Now again, we can compare that with drugs, new drugs, or new medical devices, or possibly new diagnostic procedures. These tend to be highly regulated. I mean, particularly new drugs. We put huge energies into regulating new drugs and trying to establish is there evidence of benefit, and does that benefit justify any increased risk as a consequence of the new drug. And so a lot of effort goes into establishing the safety of new therapies. Public health, it doesn't. There's no real regulator there. We certainly don't have an equivalent of the EMA, European Medicines Agency, or in the United States, the FDA, the Food and Drug Administration. There isn't a body like that who oversees public health interventions. I guess as a public health doctor or something, you could try anything. Because no one's going to, well, if you need some resources to try it, but it doesn't seem to be regulated. So I think that has an effect on study design. But I think a bigger one is randomization is just hard to achieve. Final observation here, I think, is one that really just applies across the board in healthcare. It's not just public health interventions. It also obviously applies new drugs, new procedures, and that is the proximate effect of an intervention almost always needs to be modeled in terms of some more useful measure of outcome, and over quite a long time period. So in public health, for example, suppose the intervention was to try and reduce smoking prevalence in the community. Now, the short-term or proximate outcome, if it's successful, is a reduction in the amount of smoking, or number of smokers, proportion of smokers. But we're not really interested in that as such. It's the benefits we get from reduced levels of smoking. Things like reduction in cardiovascular risk, which then leads to ultimately reduction in stroke, reduction in myocardial infarction, etc. And even then, we're not just interested in how many strokes we'll prevent or how many heart attacks we prevent. We're interested in what's the consequences of preventing strokes. And so there'll be patients living longer, patients in better health states than they otherwise would have been. And so it's really quite common that the proximate effect, the immediate consequence of an intervention, when we're doing evaluation, needs to be modeled so that we can predict what's going to happen to some more relevant outcome, such as patient survival or health changes in health state. Now, that is not just a feature of public health interventions. Of course, that's a feature of things like new drugs as well. You know, the new drug lowers cholesterol, fine. But we're not interested in lower cholesterol as such. We're interested in lower cholesterol because for some patients, that's then going to reduce their risk of things like stroke. And then the reduction in stroke has consequences for health. So that one wasn't so much a difference between public health and other healthcare. Continuing with the challenges, it's going to be important when we evaluate public health interventions to have some sort of standard unit of account or way of measuring outcome. Otherwise, we're not going to be able to compare different public health interventions. So if we don't standardize our measure of outcome, and if we have different outcomes for different interventions, how do we know which intervention represents better value? We don't. So we do need to standardize. Now, I think, and again, that is the same as for things like looking at new drugs. I think there is a difference, though. And I think the difference is this. It appears that perhaps monetary valuation is a bit more useful or has greater potential when we're evaluating public health interventions than possibly when we're looking at new drugs. Now, with new drugs, the standard that has emerged is to use things like the cost per additional QALY produced. The quite powerful reasons why we don't use money. And in the presentation on Wednesday afternoon, I ran through a lot of the challenges of using money as a means of valuing health outcomes. In the public health field, however, there seems to be a much greater willingness to consider monetary valuation as an approach. And I think the reason for this is there's a much wider range of effects. So with a new drug, as I've said, perhaps the main effect or the only effect is some impact on the patient's health. But with a public health intervention, and we'll see this by way of example shortly, there's many possible different effects that we're interested in achieving. And once you've got multiple effects, maybe something like the QALY or DALY becomes less useful or becomes harder to measure everything in terms of the QALY or DALY. And perhaps it then becomes easier, or the argument for using money as a standard becomes greater.